I'm doing my...
This is Dr. Mullins. She's one of our PGY3s. She's doing her grand rounds. She's one of our excellent chiefs.
Aw, thanks. Thanks for that introduction. So chronic pelvic pain, this is something that we see pretty frequently as OBGYNs, and I feel like it's an area of weakness for not only myself, but maybe for other people. So I was going to talk about it and try to educate everyone. So I don't have anything to disclose. So what is chronic pelvic pain? Well, there's not a universally accepted definition, but many people distinguish it from dysmenorrhea and dyspareunia, and Williams Gynecology defines it as a non-cyclic pain that persists for 6 or more months, pain that is localized to the anatomic pelvis, to the anterior abdominal wall, at or below the umbilicus, or to the lumbosacral back or buttocks. It is pain that is of sufficient severity to cause functional disability or lead to medical intervention. So I said it was common, but how common is it? The prevalence of chronic pelvic pain is 3.8% in women aged 15 to 73. In reproductive aged women, it's higher, it's 15%. 39% of women in primary care practices complain of pelvic pain, and it accounts for 10% of all the referrals that we get as gynecologists. It's the indication for 12% of hysterectomies and over 40% of GYN diagnostic laparoscopies. To compare it to other common conditions, the prevalence of migraine headaches is 2.1%, asthma is 3.7%, back pain 4.1%. It's pretty expensive, so the direct cost of health care for chronic pelvic pain in the United States alone is estimated to be $2 billion a year. And on an individual basis, it can lead to years of disability, suffering with loss of employment, marital discord, and divorce. So before I talk about the differential diagnosis of chronic pelvic pain, I was going to talk a little bit about pathophysiology of pain in general. So we as physicians should understand the mechanisms that underlie the human perception of pain. This involves a complex physical, biochemical, emotional, and social interaction. It's subjective, it's ambiguous, and sometimes it's difficult to diagnose and to treat. Pain is a protective mechanism that's meant to warn us of an immediate threat and to prompt us to withdraw from a noxious stimuli. It's usually followed by an emotional response and behavioral consequences. Persistent pain can be visceral, somatic, or mixed, and pathology in one organ can commonly lead to dysfunction in adjacent systems. So somatic pain. This comes from the somatic nervous system. This innervates the parietal peritoneum, skin, muscles, and subcutaneous tissues. This type of pain is generally sharp and localized, and it's usually found on either the right or the left side and within the dermatome that corresponds to the innervation of the tissue. Visceral pain, on the other hand, comes from its fibers from the autonomic nervous system. This innervates viscera and visceral peritoneum. These fibers are more sparse, so the pain is usually described as a dull ache. The pain localizes to the midline because visceral innervation of abdominal organs is usually bilateral. Inflammatory pain. So inflammation usually follows tissue injury. Body fluids and inflammatory proteins are called to the injury site. You get vasodilation and increased capillary permeability. Pain perception in inflamed tissues is increased because the inflammatory process itself lowers the conduction threshold of your pain receptors, and this is called peripheral sensitization. As inflammation decreases, the increased sensitivity to stimuli and perception of pain also decreases. Neuropathic pain. This is thought to underlie many of the chronic pelvic pain syndromes. In some people, you get sustained noxious stimuli. This leads to persistent central sensitization and a permanent loss of neuronal inhibition. The result of this, you get a decreased threshold to painful stimuli, and this remains despite the inciting stimuli being removed. So this helps explain why many people with chronic pain have discomfort disproportionately greater than the amount of disease that you find. During this sensitization, multiple repetitions of lower level stimuli over time result in a more severe perception of pain. Why do we get referred pain? For 2 reasons. So your visceral efferent fibers are poorly myelinated, so that way whenever the brain processes these fibers, it can be referred to dermatomes that correspond to the adjacent somatic nerves. And then the peripheral somatic and visceral nerves, they synapse in the spinal cord at the same spot in the dorsal horn neurons. So what you get is sensory information to the brain coming from the same dermatome, whether it's visceral or somatic. So now differential diagnosis. So I found 6 systems that are potentially involved in chronic pelvic pain. Sometimes you hear there's 5. Really the neurologic and miscellaneous categories here can be combined into one to make it 5. So we have GYN origin, GI, urologic, musculoskeletal, neurologic, and miscellaneous. There is a long list of pathologies. It's pretty extensive, and it includes both organic and psychological dysfunctions. So for GYN etiologies, you can probably ask any of us in the room and we can tell you endometriosis as a cause for chronic pelvic pain, but some of these are a little bit more rare and things that we might not think about. So I'm not going to read them all to you, but we have endometriosis, adenomyosis, fibroids, ovarian masses. That's the stuff that we can recall pretty easy. But pelvic congestion syndrome and broad ligament herniation, those are things that are probably not high on our differential list. GI, irritable bowel syndrome, or IBS, that's the main one there. Also constipation, diverticular disease, cancer, celiac disease. For urinary system, interstitial cystitis is the big one, chronic UTI. You can get stones, cancer, urethral diverticulum. For musculoskeletal, hernias, muscular strains, faulty posture. Again, I'm not going to read the whole list. Neurologic, any kind of neurologic dysfunction. You can get neuralgia of different nerves, the iliohypogastric, you can get pudendal neuralgia, spinal cord or sacral nerve tumors. And then for miscellaneous, the big one here is physical or sexual abuse, psychiatric disorders, and I also found a site that listed shingles as a possible differential. So to make the diagnosis, realize chronic pelvic pain is multifactorial. Making the diagnosis is difficult, and you need to try to narrow down the differential to be able to treat. So you perform a history and physical. You should address all the possible systems that are potentially involved. You can use a pelvic pain questionnaire and a body silhouette diagram, and I've included a couple of those to show examples. You can also perform labs, imaging, and surgery to help you make the diagnosis. So here's a sample pelvic pain questionnaire. So it has real simple questions like how old are you, how many pregnancies have you had. It's a list of 24 questions, and then it even asks what do you believe or fear is the cause of your pain, because sometimes that's important, thinking what's the patient think is going on. And for your body diagram, they can circle the area of pain. So when someone circles right below their rib cage, thinking that that's the cause of their 1 centimeter ovarian cyst that the ER ultrasound found, it's probably not their ovarian cyst that's causing their pain. So know their location of pain. Use that pain map. Have them circle the areas that are sources of pain. 60% of women with chronic pelvic pain also have headaches. 90% also have backaches. They might circle locations on that map that shows a dermatomal distribution, and that suggests a non-visceral source. pain of visceral origin, like I said earlier, is not well localized. So patients have a hard time differentiating between GYN, urologic, or GI sources of pain. If the pain is on both the ventral and the dorsal aspect of the body, then that suggests an intrapelvic pathology, but when it's only dorsal in the lower back, that suggests a musculoskeletal or orthopedic pathology. Know about the pain severity and the quality. So just asking about pain and finding out if there's no pain, mild pain, severe pain, that's not really very useful. You should get a better history, find out how long the pain lasts, when does it occur, does it affect their daily life and activities, how has the pain changed over time, is there a temporal pattern of pain? So if it's cyclic and related to menses, that suggests a GYN origin, but it's not pathognomonic for GYN disease. You can get cyclic patterns with GI, urinary, and musculoskeletal origins as well. And IBS symptoms frequently increase premenstrually. Obstetric history, 9% of postpartum patients have continued genital or pelvic pain for more than a year after delivery. Remember that pregnancy and delivery are traumatic to the neuromuscular structures. They've been linked with pain, pelvic organ prolapse, symphysial or sacroiliac joint pain. Also know if there's a history of infertility and no prior pregnancies, because there can be a diagnosis linking both infertility and their pain, such as endometriosis, chronic inflammatory disease, or adhesions. Any past surgery, especially surgery for pain, is pertinent. One source that I was reading listed a couple case reports that identified gallstones that were spilled at the time of laparoscopic or open coles as a cause for chronic pelvic pain. So that's something that we might not think about. Prior cervical surgeries, leaps and cervical cones with resulting chronic pelvic pain, you might think hematometra with that. Get a psychosocial history. So there's significant association between chronic pelvic pain and physical, emotional, or sexual abuse. An extensive history most likely will require evaluation by a psychologist, and it can't always be done, but we can always ask about depression. That's important. It's one of the several predictors of pain severity in women with chronic pelvic pain, and it's a significant indicator of their response to treatment. So on physical exam, this requires a pretty systematic, methodical attempt to duplicate their pain. You palpate and position them in different positions. So you divide the exam into standing, sitting, supine, lithotomy positions, and you evaluate the musculoskeletal, GI, urinary, and psychoneurological systems. I didn't include a detailed physical exam in this presentation, but Williams Gynecology has a really good section on physical exam. You can get labs. Once you've gotten a history, you've performed your physical, that narrows down to what labs you might need. So you can get a UA, urine culture, if you're thinking that UTI, urinary tract stones, or malignancy is a possibility. Checking for diabetes, which can lead to neuropathy. You can check a thyroid, a TSH, because thyroid disease can cause patients' bowel or bladder symptoms, and testing for gonorrhea and chlamydia if that's indicated. Imaging is next. So if you feel like a patient needs imaging, transvaginal ultrasound is the preferred method for evaluating uterus, ovaries, and diagnosing any kind of GYN disease. You might see an endometrioma, fibroid, ovarian cyst, dilated pelvic veins, or any kind of structural lesion. You can also get a CT or an MRI, but that usually doesn't add a whole lot of information that you can't get from an ultrasound. If a patient is having predominant bowel symptoms, you can think colonoscopy or barium enema. If they're having urinary symptoms that are predominating, cystoscopy. And laparoscopy is considered by some as the gold standard for evaluating chronic pelvic pain. And it's frequently performed on women who have no obvious cause. Take a look and see what's going on inside. So over 40% of GYN diagnostic laps are performed for chronic pelvic pain, and 36% of these have normal findings, suggesting that they have another source for their pain. There's something called conscious laparoscopic pain mapping, and this is performed under local anesthesia with or without conscious sedation, and that's when you gently probe or traction different tissues, asking the patient, is this what hurts? Is this what hurts? I don't know how often that's done, but it's an option. So you have your history and your physical exam and your imaging, and now how are you going to treat this chronic pelvic pain? Well, it depends on their etiology. After 4 to 6 months of having chronic pain, pain itself can become an illness, so it's a disease itself and it's not just a symptom. And treatments that you can possibly use are both pharmacologic, psychologic, and surgical. So for pharmacologic therapy and analgesics, remember that, or just know that pain reception, transmission, and perception involves several neurotransmitters, neural links, so there's several different options to use. You can have peripherally acting analgesics such as aspirin and NSAIDs and Tylenol, acetaminophen, very effective. Or you can have central acting analgesics such as opioids, which are also very effective, but they're controversial. So opioids are very effective and the least addictive if given on a scheduled basis and at doses that are adequately relieving pain. 3 to 16% of chronic pain patients have addiction to opioids, and 55 to 71% of patients referred to chronic pain centers are taking opioids on a regular basis. The opioid maintenance therapy for chronic pelvic pain should be considered only after other reasonable attempts at pain control have failed, and when persistent pain is a major impediment to improving their function and daily activities. You can try antidepressants. So TCAs are used to treat many chronic pain syndromes. They've been shown to reduce neuropathic pain independent of their antidepressant effects. So their proposed mechanism of action is to improve pain tolerance, restore sleep, and reduce depressive syndromes. And amitriptyline and nortriptyline are the TCAs best documented in treating neuropathic and non-neuropathic pain. SSRIs don't appear to be quite as effective as TCAs, and there's also anticonvulsants that have been used and are effective, so gabapentin and carbamazepine. You can try a combination therapy, so you can combine a central and a peripheral acting analgesic, so an NSAID and an opioid. You can combine 2 centrally acting medications, an opioid and antidepressant, or you can add a muscle relaxer to either an NSAID or an opioid. You can also consider hormonal suppression, and this is especially if they don't have a dominant bowel or bladder symptom. So you can try combination OCPs, progestin, a GnRH agonist such as leuprolide. Certain androgens have also proven effective. For psychologic therapy, the majority of women with chronic pelvic pain have psychosocial problems that need attention just on their own accord. So it's also been suggested that women with psychosocial problems such as sexual abuse, marital discord, personality disorders, difficulty maintaining relationships, that these people are more vulnerable to pain signals and that they're ill-equipped to cope with uncomfortable somatic sensations that accompany their disease process. Pain psychology is a type of treatment that assists women with chronic pain, chronic pelvic pain, to focus on the positives in their life and encourage them to take an active role in dealing with their pain. Surgical therapy. So hysterectomy. 12% of hysterectomies are performed with chronic pelvic pain as their primary indication. Total hysterectomy with BSO is considered definitive management when thorough evaluation excludes inorganic cause and conservative medical therapy has failed. So this occurs despite the fact that over 70% of the possible etiologies to developing chronic pelvic pain are not GYN in origin. Almost 40% of women with no identified pelvic pathology will have persistent pain after their hysterectomy, and 5% might have increased pain. But for some women with chronic pelvic pain, hysterectomy is effective in resolving their pain and improving their quality of life. but for others, it fails to relieve their pain. This is more common in women who are younger than 30, those with a mental illness, like I discussed before, or if they just don't have an identifiable pelvic pathology prior to their hysterectomy. 14% of women report having pain or results worse than expected, and 26% of women report having a slower recovery than expected. There's also neuroablative treatments as a surgical option. This is surgical transection or excision of nerves, injection of neurotoxic chemicals, or use of energy that destroys the neural tissue. So this is most often used to treat a particular nerve dysfunction, such as like a trapped ilio-hypogastric nerve, but it can also be used centrally to decrease pain even if you don't have a specific diagnosis or a specific nerve dysfunction. A couple examples: presacral neurectomy. This is excision of the hypogastric plexus or the presacral nerve. This carries somatic pain fibers from the uterus. It's performed most often for severe dysmenorrhea or endometriosis-associated pelvic pain. Of people who have this performed, 75% note a greater than 50% decline in pain. But it is a technically challenging procedure, and it has been associated with post-op complications of long-term constipation and urinary retention. A couple other neuroablative treatments is paracervical denervation, which is transecting the uterosacral ligaments. That is performed for relief of dysmenorrhea, but not usually chronic pelvic pain. And uterovaginal ganglion excision, where you're excising the inferior hypogastric plexus, which carries parasympathetic and sympathetic nerves bilaterally at the base of the broad ligament lateral to the cervix. So that was all general treatments: analgesics, hormonal, surgical, psychological. I'm going to talk briefly about some of the more common diagnosis of chronic pelvic pain. Each of these things can probably have a whole Grand Rounds topic devoted to each of them, but I'm going to briefly talk about endometriosis, adhesions, IBS, and interstitial cystitis. So endometriosis. The incidence is hard to quantify because many people are asymptomatic. Using laparoscopy with or without biopsy as the method of diagnosis, the annual incidence of surgically diagnosed endometriosis is 1.6 cases per 1,000 women aged 15 to 49 years. So in asymptomatic women, the prevalence ranges from 2 to 22% depending on what population you study. Prevalence in women with infertility is 20 to 50%, and in those with pelvic pain, 40 to 50%. The extent of disease does not always correlate with the symptom severity. So someone with very mild stage 1 endometriosis might complain of pretty severe pelvic pain, where stage 4, their pelvic pain is not severe. Proposed mechanisms for the pain include inflammatory, nociceptive, and neuropathic. You can treat it medically or surgically. So if you treat it surgically at the time of diagnostic laparoscopy for stage 1, 2, and 3, that has been shown to decrease pain symptoms. Presacral neurectomy has also been shown to be effective for dysmenorrhea. GnRH agonists, like leuprolide, have been shown to decrease pelvic pain. When you compare surgical treatment with the leuprolide, there's no difference in efficacy between the two methods. If pain recurs within a year after treating with leuprolide, retreatment appears to be reasonably effective. 2/3 of these patients show a significant reduction in pain during retreatment, but you might want to consider an add-back therapy with estrogen or progestin to decrease their loss of bone density and hot flashes. This add-back therapy might also increase their likelihood of breakthrough bleeding and breakthrough pain symptoms, though. In the May of 2014 Green Journal, in the section of What's New over the last year, there was a couple articles on chronic pelvic pain. And this is what's new over the last year that's important with chronic pelvic pain. So one was that a study showed an antioxidant therapy with vitamin C and E can help reduce endometriosis associated chronic pelvic pain that's unrelated to menses. And the other study showed that treatment with melatonin, which was at a dose higher than what you would treat insomnia with, also showed to improve daily pain, dysmenorrhea, dysuria, dyschezia, and help sleep in women with endometriosis. IBS. Prevalence in the general population is 10%. It's abdominal pain that improves with defecation. It's associated with a change in bowel habits. Symptoms of IBS are present in about 50 to 80% of women with chronic pelvic pain. In women with IBS between 18 and 40, 21% have had hysterectomies. So this is significantly higher than the national average of 6%. So it's unsure if this represents just inaccurate diagnosis by GYNs or the presence of multiple disorders in women with IBS. To diagnose it, you want to exclude organic disease, and in young patients with typical IBS symptoms, few tests are required. It's a diagnosis of exclusion. Some of the treatments, you can have dietary treatments as the mainstay of therapy, but most of these dietary interventions are not experimentally validated. So you can eliminate lactose, sorbitol, and fructose, reduce caffeine and carbonated products, smoking and chewing gum. These can all lead to bloating. Eliminate excessive alcohol consumption. It can lead to rectal urgency. And you can try medications. So for abdominal pain, gas, and bloating, and antispasmodics such as bentyl or dicyclomine or Levsin or hyoscyamine, those are potential options. For gas or bloating symptoms, Beano or Gas-X. Constipation, increase fiber or add stool softener or an osmotic laxative, but you want to avoid chronic use of stimulant laxatives. For diarrhea, try Imodium. Peppermint oil has also been shown to decrease abdominal distension, reduce stool frequency, and flatulence. And TCAs might also help with IBS by having both an anticholinergic effect on gut and by modifying mood. They might slow GI transit time and have been shown to be effective in diarrhea, dominant IBS. Interstitial cystitis. So the prevalence here is 30 to 60 in 100,000. It's a chronic inflammatory disorder of the bladder with symptoms of pelvic pain, urgency, and frequency. So you remember interstitial cystitis and puff. Diagnosis, it's based on their voiding symptoms that they complain of without an objective evidence of another disease that could be causing their symptoms. You can perform cystoscopy. 10% of women who have cystoscopy will have Hunter ulcers. These are the reddish-brown mucosal lesions that have small vessels radiating towards the central scar. But more often they might have glomerulations, which are small petechiae and submucosal hemorrhages. How do we treat this? You can treat it by dietary restriction of irritating food. So spicy and acidic foods typically cause interstitial cystitis to worsen. Also alcohol, carbonated and caffeinated beverages. You can try Elmeron, which is an oral agent, pentosan polysulfate sodium. It is the only FDA-approved oral medication for interstitial cystitis. You can also try amitriptyline, TCA, or an antihistamine. You can try instillations, so instilling the bladder with heparin or DMSO. You can try bladder hydrodistension. This is done in the OR under general anesthesia, or just anesthesia in general, just because distending your bladder is painful. There's been some success reported with destruction of the vesicoureteric plexus, and also in that green journal that I mentioned earlier with the What's New in Pelvic Pain section, it showed that physical therapy might reduce pain associated with interstitial cystitis. It recommended further study in that area, but it shows promise. Adhesions. So about 25% of women with chronic pelvic pain have this diagnosis, but their role as a cause for chronic pelvic pain is somewhat controversial. It's believed to cause pain when adhesions distort your normal anatomy or when movement stretches the peritoneum or the organs serosa. 40% of patients who undergo diagnostic laparoscopy are found to have adhesions. Risk factors are prior surgery, prior infection, endometriosis, and less commonly you might see adhesions formed from radiation, chemical irritation, or foreign body reaction. There was 2 randomized studies that I saw in 1992 and 2003 that compared lysis of adhesions with expectant management, and they found no difference in pain scores after 1 year. But there was a small subgroup of women who had severe stage 4 adhesions that did show some improvement in pain. And then in conscious pain mapping that I mentioned earlier, where you perform that under local anesthesia during laparoscopy, it showed that the filmy adhesions that allowed more movement had higher association with pain, where adhesions that prohibited movement and that were thicker, they had lower pain scores. Also, adhesions that had a relationship to the peritoneum had a higher association of pain. So in summary, what do you take home from all of this stuff? So know that chronic pelvic pain is non-cyclic pain. It lasts for 6 or more months. It is leading to years of disability and suffering with loss of employment, marital discord, and divorce. Its prevalence in the reproductive age woman is 15%. It accounts for 10% of all the referrals to us, to the patients that we see. It's the indication for 12% of all hysterectomies and 40% of all GYN diagnostic laps. Over 40% of women who have had a hysterectomy still have continued pain. Know that pain is subjective, it's ambiguous, it's difficult to diagnose and to treat, and then realize that there's 6 systems that are potentially involved with chronic pelvic pain. Again, GYN, GI, urinary, musculoskeletal, neurologic, and then the miscellaneous that can be combined with a neurologic. Over 70% of the etiologies to developing chronic pelvic pain are not GYN in origin. You need a thorough history and physical exam. I recommend reading Williams' gynecology section on the physical exam. You can perform diagnostic tests, labs, imaging, surgery, and then the treatment depends on the etiology. It includes pharmacologic, psychologic, and surgical options. My references.
Oh.
That's all I have. Questions?
Do you know if we ever do that conscious laparoscopic pain mapping?
I've never heard of anyone doing it before. I read about it and it mentioned it, but I don't know, has anyone else ever seen that done?
I understand they use a 2mm scope, and it's done in the office, which of course then gives you the risk of hitting. I mean, if you hit a big vessel with a 2mm scope, you've got a big problem. So that's sort of why we never thought it was something that we want to do because of that risk. But I think it's just your local lidocaine, and your usual technique is just a 2mm scope. And then
Asking what hurts. Is this what hurts? Is this what hurts? Anything else? I explained it that good?